Thank you. 60% of my job is here.
I get it.
Can everyone on Zoom hear now?
Yes, we can now hear.
You can hear now. Okay, sorry, there was a mute.
So should I start?
Do you mind going back to the beginning?
Okay.
You're more.
Thank
Sorry.
you.
Yeah.
Sorry about
So I was introducing Tanzania as a seaport country, one of the 8 member countries of the East Africa community. It's the southernmost
This
country
guy's
in
opening
East
slide
Africa.
says Tanzania is a seaport country located in the eastern coast of Africa, one of the largest countries in the regional bloc. Population 63 plus million. And he spells seaport two
John,
different
can you
words.
mute?
S-E.
Okay, there you go. Sorry. Thanks for, we're really engaged. This is great. Okay, go ahead.
So our population is 62 million plus. We just did our national census recently. It's largely composed of the young. That's making, as we'll see later, financing difficulties because most are either under 18. Majority, actually 45% of the population are under 14 and elderly. The workforce, the active workforce is very small. 19.3% of the deaths that we record in the country and 17% of deaths are attributable to diseases that are amenable to surgery, including things like filarial hydrocele and hernia. And road traffic trauma is very rampant. And we also have a poorly distributed surgical, obstetric, and anesthesia workforce. But of importance is that we don't capture data on types of surgery that are going on, including their outcome. We have a national health information management system that captures everything except surgery. And that's because surgery has not received proper attention, as we both know, in a global perspective. And the lack of surgery was not used as an indicator of development, unlike maternal mortality and under 5 mortality. It stacks. You can move it for me manually? Yeah. So this a map that we recently published with Nathan when we were looking at the surgical oncology per capacity, and I thought it would be nice to use it just to highlight on our health system. So this is the map of Tanzania. This is Lake Victoria, and on top here we have Kenya, and to the left we have Uganda, we have Rwanda here, and we have Burundi here, and we have Democratic Republic of Congo here, and on top we have, of course, Southern Sudan and Ethiopia as member countries of the East Africa community. So the demarcations you are seeing are regional demarcations. So our health system is arranged in from national. The purple one you're seeing is national hospital. It's only one. That's where we work, me and Dr. Mwanga. And the green are the zonal referral hospitals. There are a little bit tertiary hospitals. And the remaining regions have what we would call regional hospitals. And if you zoom in further, you find the districts forming regions, and you'll be having district hospitals, and we'll be looking at what their roles would be. So this you find in our publication on surgical oncology capacity in the country. I'm not intending to talk about the numbers, but the numbers tell you how much surgical oncology is being done. It's still less. Next slide. So to address all the challenges that we spoke about, we got funded through a consortia of collaborators led by JH Pygo and General Electric from Europe. And so we developed our first very comprehensive national surgical obstetric and anesthesia plan. And in developing this, I think Ghana had developed theirs before. And there were some difficulties with how to roll out the Ghanaian approach to NSWAP. So when we developed the Tanzanian model, it was very comprehensive, and many countries later followed to develop their own NSWAP programs. So it was meant to address the surgical needs, and many countries now have this, and we have it. And the aim was to ensure that we have safe, affordable, and timely surgery, as were identified by the Lancet Commission of 2015, that people were using more than 2 hours to access care. Of course, using 2 hours is debatable. You might be within a local city, and an hospital is, you might think literally it's within 2 hours, but poor roads and traffic jams and everything, it might take you 3 hours to move within Dar es Salaam. So it was technically difficult to use 2 hours as a matrix. And we will see what we did as a country. And also to make surgery affordable, and we will see later the issues of catastrophic expenditure and impoverishing expenditures have been defined by Lancet, were very prevalent in Tanzania. But of most important to us as a profession was to make it safe. And safety here covered areas like having safe anesthesia, which is still a problem, having blood available. Blood is a problem. The United States, following the twin bombing of US and Dar es Salaam embassies, helped Tanzania to establish a national blood transfusion system, which were initially very well funded with zonal establishment. So the zones that I showed you, all of them have well-established blood system, but they are not communicating. So one zone might be having more blood than they can use, and blood expires and they throw it out. And in another zone, they have severe shortage of blood. And now with funding circle over, they are no longer funded by USAID. They are facing financial obstacles to ensure we have safe blood. Did it move? Oh. And critical care provision was also a problem. ICU was only available at the national level. And this was only a physical infrastructure. Whether staff were trained to offer services in the ICU was another problem. And when Bill Schechter first visited us, he realized this was a major obstacle to do any major laparotomy in Tanzania. We had very high mortality, and we partnered to help bring critical care nurses to help with the critical care services in Tanzania, and we oriented our surgical trainees on critical care. The other one was SOA providers. We had a mixture of providers. We had surgeons, we had medical doctors, and we had non-physicians offering surgical services. And we realized that we cannot say that surgical services will be offered by surgeons because we had less than 100 surgeons at that time. Less than 100, all surgical workforce in the country. So the bulk of the surgery was being offered by non-physician assistants in the district hospitals and in the regional hospitals. So even when a surgeon was said to be a region with one surgeon, but you find it a surgeon with administrative responsibilities, regional medical officer. We famously called them regular missing officers because they are in one meeting to the other. So they are not there. So literally they say like, yes, that region as a surgeon, but it's a surgeon who is not there. So normally when you posted a surgeon, you will not post a gynecologist because you assume the surgeon will cover the roles of a gynecologist. The same assumption was being extended that if you post a gynecologist, you don't post a surgeon, but gynecologists are afraid of the bowel. They have bowel perforation, they want a surgeon. So there were problems. So we relied heavily on non-physician providers and a bunch of medical officers who would be employed in the departments of surgery. The infrastructure was also not very good. Many hospitals were called regional, but it was just an upgrading of what was considered a district hospital with poor infrastructure. The operating room was far away from the radiology, was far away from what would be considered post-op area. The floor inside from the time patient enters to the operating room and outside was not synchronized, so there were lots of infection. There's no data collection to know what patients had complications and improvement, the sterilization. So all these had problems and were to be addressed by the MSWA program. Next. So our MSWAP had 6 domains, as you all know, of the Lancet domains to ensure safe delivery. So one was to look at the service delivery aspect, and we costed each of the 6 domains. And when I first presented this to the Ministry of Health, the first question they asked me, who's giving the money? And I said that was not our role. Our role was to show you what we needed to offer safe, affordable, and timely surgery. So it's your role to look for partners. So it looked impossible, an impossible undertaking. But we will see later there was a political will to address it. So they were not actually working through the NSWAP, but we were monitoring the deliverables, and we realized that they were actually implementing our NSWAP without actually looking into it. So one was to ensure equitable distribution of SOA services throughout Tanzania, from health centers to national hospital. And we will see that we upgraded so many health center level facilities to have operating rooms, to have more inpatient services, to have some few anesthesia machines. Actually, each health center had 2 rooms, fully equipped with anesthetic machines. And then human resource became a problem. How do you get human resource if you are expanded surgical services to 300 new lower facilities that never existed? So that became a problem. Initially, when me and Mwanga graduated, they were begging us to pick positions for employment. There was so much positions than the number of medical doctors available. And so the number of universities training medical doctors increased from traditional 3 that we have to over 9. And training abroad also jumped up. So now we have over 3,000 interns every year, 3,000 medical doctors taking internship every year. And the government can only employ 100 every year. So you can see the number of doctors that have been available in the market for the past 6 years that have not been absorbed. So we realized that potential, and we realized that we can tap into that potential now to convert them into SOA workforce. So we had both intermediate, we had short-term, intermediate, and long-term. Short-term was to restructure the internship so that an intern is either only SOA or medical. If they are SOA, they are only doing general surgery, obstetric, and anesthesia, so that when you deploy them, they are competent in that area. Or they are only doing medical, which would be internal medicine and pediatrics. So you pair the 2, you pair 1 SOA and 1 medical to have your surgical services delivered. We have not achieved that. It's still a logistical problem, but that was one of the options. The other option was to do the Zimbabwe approach, where you give a shorter training post-internship to medical doctors as SOA providers. And the longer one was to expand training. So we expanded training, and sitting as head of department, it frustrates because they give you more trainees and they are not expanding the infrastructure for training them. So we normally took 5 residents, and now we are taking 20 a year. So that's a significant increase in all the training sites, and that gives us over 60 SOA surgery alone every year. But again, they're still remaining in the capital city. They are not going out. So we are still failing there. So we also wanted to improve the national SOA referral system. And with the coming of reimbursing per patient, this is getting obstacles. Many hospitals would like to retain patients because they want the money from the insurer. And we are working on demotivating, staying with the patients, and encourage referring patients early rather than referring them late. So we'll see our referral path. We also wanted to strengthen perioperative services at the health facilities, and we will see the blessings that COVID brought. In spite of taking away some of our loved ones, we did not have very high fatality rates with COVID, one of the countries that did not lock down. But the funding that came to relieve COVID, most of it went to improve health services. And we will see that there's a lot of improvement in the perioperative care for patients, including improvement in critical care services at hospitals levels. And we also have outreach services that are now regular and more predictable, largely focusing on obstetric. But from this year, surgeons will be paired to the district hospital. So you are assigned a district hospital as a mentor, and you visit regularly, including supporting them with telemedicine. Domain 2 was infrastructure. This was the most expensive domain. They asked me, who is going to find the money to construct all this upgrading of health centers, all these new district hospitals, all these new regional hospitals. And thanks now we have all public health centers upgraded to have 2 operating rooms, to have more additional rooms to accommodate both male and female post-surgical cases, strengthened laboratories, strengthened ambulance services, and strengthened more district hospitals in districts that did not have hospitals, new regional hospitals in regions that did not have regional hospitals. That was the most expensive, and we now have it well covered. So one of the problems in Africa, as you know, those who have visited, is electricity. Recently, we had one of the biggest power rationings in Tanzania in years. So the question was, you are going to have all this infrastructure at the health center. What about electricity? What if electricity goes off? So we had plans that would provide standby generators to all these facilities. And as you know, fueling some facilities went for solar, and we managed because we costed it. And supply chain, of course, improvement, whereby traditionally the hospitals, the health centers were being supplied by the district hospitals. So the district would be satisfied before it sends down supplies to the health centers. Now what is happening is each facility is being supplied directly from the medical stores department. We have a national level medical stores department where all facilities have their accounts. So if consumables are meant for health center X in a district, it will be transported directly from the medical stores department at national level to that facility. So that has improved availability of consumables that would address SOA services, including medicines and medical supplies, and increase accessibility and utilization of safe blood. Traditionally, blood was collected and sent. So you collect blood, but you send it to where the zonal blood bank is. So you would see the cost that the blood is collected 500 kilometers and you need to send it to the region, and you send the whole blood, and then they'll decide how much they're returning to you. So now you collect blood and you keep it. You only send samples for testing so that they test for HIV and ensure it is safe, and they will bring you back information that blood 1, 2, 3 is not safe, remove it. Blood 1, 2, 3 is safe, you can use it. So people are remaining with their blood. So that has made sure that blood is available in the hospitals. And establish capacity for equipment maintenance and repair. Actually, this is one of the biggest problems, I think, not only for Tanzania, but for the whole region, especially if you are relying on donated equipments. Many of them will go out of service in the shortest time possible because of lack of maintenance. Now we have started programs, educational programs that produce biomedical engineers, including a degree program at our university. Next. Human resource, the aim was to increase physician density, which we are struggling to increase. We have increased them theoretically, but you are like stranded in the ocean and thirsty. We have plenty, and now the wage bill comes in because the biggest employer is the government. So the government can no longer expand its wage bill. World Bank will say, no, you have stretched too much. So government either has to look at services that it is willing to let go private so that it refocuses on strengthening healthcare workforce. We have more than they can take. Ensure equitable distribution. This has been a problem. In my department of surgery, we are many, very many. But you go to a regional hospitals, there's nobody. So the plan was to redistribute so that you are not having abundance while somebody is not having. And this has been a political problem. The Minister of Health has always directed, please redistribute. You appoint a new director, he comes and will try to look at workforce, how much should be seen by a single provider, and they will tell you, we need more. So it's like one person is needing more because they're in urban and people are willing to take up positions, and the other person is not having completely because they are rural. So more rurally placed hospitals are suffering in Tanzania, and urban placed hostels are having more. Actually, 3/4 of surgical workforce is in Dar es Salaam, the capital, the commercial capital of Tanzania. 3/4. In a country of 60 million people, 3/4 are serving 6 million people. So we wanted to redefine the role of allied health professionals and task sharing. What we had done before was task shifting. We had shifted the task. We completely abandoned our tasks. And we were completely very comfortable with an MD taking a specialist task. If you share task, there will be safety guaranteed. It's just like you're having residents. You know what to allow them, how to help them make decision. But if you shift, you're completely not there. It's none of your business. They're just doing it. So we went back and said we want task sharing and limit task shifting. And we piloted several options in task sharing with CHESA in the northern zone of Tanzania, where we paired surgeons with hospitals. And so they would develop a mentorship relationship where they would be discussing cases together over Zoom. And when they are intra-op and stuck, you are prepared that you can be called anytime, including in the middle of the night. You'll be sharing pictures by WhatsApp, and you'll be telling them what to do. And 4 times a year, you'll visit them and stay with them for a week. So we thought that was working much better. But from the central government, they thought they wanted outreach programs. So recently I argued with the Minister of Health, and we agreed that outreach do not build capacity. Outreach delivers services to patients, but you are leaving the local team the way you found them. So we agreed that we are going back to mentorship. So the whole country will be mentored. So I will be assigned a district hospital that I will visit as a general surgeon, a colleague from gynecology, and a colleague from anesthesia. So we are paired to one district hospital. So we'll be mentoring that district hospital for a year, because we are not seeing a surgeon being placed, a SOA, a specialist SOA being placed in the district hospital in the next 10 years, because we are still having gaps to fill in the regional hospital. So we have to build the capacity of the medical doctors that provide services. So the plan was also to have CME activities delivered around SOA services. And we already established CPD guidelines that help in form of changes in protocols and to strengthen management and leadership capacity around SOA. We are still struggling here. We're now happy that we have a designated directorate in the Ministry of Health that only looks at SOA, and one person looking at general surgery, another person directorate looking at anesthesia, and someone just looking at obstetrics, which has traditionally been there. So we hope we will achieve our SOA targets. Next. Yeah, information management and technology, while it has been there, but it has been very difficult to get SOA data. So we just completed late last year to develop SOA variables other than obstetric and gynecology that would like to be collected nationally. And we hope that this financial year, 2024-2025, we are going to have a national level data collection around SOA activities, including outcome. So we are happy that we are moving in the right direction. Without that, you don't know how you are performing as a service, how much complications you are getting. So to address what type of variables we can collect, that's when we paired with, when Nathan came with the XLab study. We're trying to pilot at a national level also the simplest variables that we can collect, and whether it would be possible to collect them at other lower level facilities so that we have uniform data. And we only looked at laparotomy in this case, and we are planning to only look at bellwether laparotomy to start with, and pilot and see how we are doing with laparotomy, and enhance telemedicine services at health facilities. So all the new health centers have telemedicine capacity in place. So we normally go out to do hydrocele, and you find a room like this, well equipped with the communication facilities, and you ask them whether they have ever even used it. They have not. So it is through mentorship that it will be able to be used. And these are some areas where we can partner together to address our educational activities utilizing the infrastructure that already assists across all public facilities in Tanzania. Next. Financing was an issue in two aspects. One was the government financing SOA activities, but the other one was making self-financing for SOA activities affordable. And so we had an issue on universal health insurance. We struggled with it the first 5 years of our previous regime, and it failed. Because all the time you look at it, you only have like 8% of the population that can buy insurance. And you have 92% of the population that we consider peasants that cannot buy insurance completely. And we had the community health fund that was in place that only had like 10% prescribers. So the government was afraid to expand your universal health insurance to make it mandatory because it would technically mean the government funding those who could not buy it. So it stalled. So last year, we passed a bill and the president signed it immediately. So we now have universal health insurance bill in place. They are completing the regulations. So the government will set aside budgets to ensure those who will not be able to buy the insurance. And they have lowered the subscription, so that many people would afford to subscribe to the universal health insurance. And that would address the 85% of the population that was considered at risk of impoverishing expenditure from health services, and the 64% that would otherwise face catastrophic health expenditure. And we have demonstrated this in the recent study on XLAP that we are just about to publish with Nathan, that a lot of patients who got surgery ended up with catastrophic expenditures. So only having universal health coverage would avoid that one. We are also arguing with government, negotiating and lobbying if we can have some ring-fenced funds. We have ring-fenced funds to send electricity to all villages. And we have ring-fenced funds to put up the standard gauge railway. So we argued the same. We can ring-fence funds around illicit substances, around alcohol, around cigarette, around sugar, around sugary drinks, and put it into health so that we have money ring-fenced for chronic conditions, because currently our national health insurance is struggling because we only subscribe 3% of salary of employees, and the government gives 3%. So it's like a 6% subscription. With lower salaries, it can only raise 500 billion Tanzanian shillings. And that's not enough to cover for cancer, trauma, dialysis, transplant, and the rest. So the insurance currently is being faced by financial difficulties. So only ring fencing other sources of funds will help alleviate and sustain our universal health scheme. Next. The last was governance. We realized that without proper governance, all the plan that we put in place would fail. So we established governance infrastructure from the community. And this week, I think, we launched and had the biggest conference on primary health care in Tanzania to bring together the community to honor their services. And we have developed programs with UNICEF to strengthen primary health care service delivery, because that's where 85% of our population is residing. So if we have governance from the community to national level, we are sure that our NSWAP activity will succeed. Actually, the target was by 2025, we have timely, affordable, and safe SOA services. We only have 1 year left to our target. We hope we will achieve it. Next. So how did we do costing that we did initially? I will show you the costing. So we initially thought of upgrading only 100 health centers. I just said we upgraded 200. We thought of working with 100 new 23 district hostels. We had districts, but they were lacking hostels. So we have new 123 public district hostels. In place of this, we had faith-based hospitals that were designated, and they are becoming a challenge to offer things like family planning. If abortion was ever acceptable in a faith-based environment, it would be difficult. So the government had decided that it was going to have its own facilities and have the faith-based only supplementing those that they think are okay with their faith. And now we have a total of 39 regional hospitals at the time of costing and 4 zonal hospitals. We have an additional one in the western part of the country. Now there are 5. And we have special hospitals, which include Muhimbili Orthopedic Institute, only doing orthopedic, trauma, and neuro. Jakaya Kikwete Cardiac Institute, only doing cardiac surgery services. And we have one national hospital, which is located in Dar es Salaam with 1,500 beds. So total, we costed for 269 hospitals based on what they were already covering. So this was the total cost. And I think for ease of understanding, we look at the dollar costs per activity. So the last column is our dollar cost, and you can see the infrastructure was totaling $276 million US. So the permanent secretary told me, in 20 years, we'll not get this money only for health. We have other pressing demands. But as I said, we had the political will and the COVID that exposed our weaknesses in case we were to tackle COVID correctly. So the government directed lots of money, including the $1 billion US from IMF to tackle COVID, all went into the infrastructure. So infrastructure is well taken care of. Information management technology is underway. The problems are here. Human resource. So putting up infrastructure is easy. Matching it with training and deployment became a difficulty. Yeah. So we thought redistribution, and we are still arguing, redistribution of the existing workforce would incur zero cost in ensuring we have SOA services up to district level facilities. Because why would you have 60 surgeons in one hospital while the other hospitals do not have completely? Yeah. So governance is in place. So human resources is our biggest problem. You can review the slide later. And we had yearly estimates, and you can look at the yearly dollars that were estimated. So we estimated that the facilities would be increasing, and we thought that the maximum increase would be realized in 2020, 2021, and 2022, and then the increase would decrease because that's when the government was putting up new infrastructure, and we figured out that the hiring cost would also be going higher with time. And inflation was considered at 7.5% to account for the annual increase in the budget. Next. So as I said earlier, our health services follow this hierarchy. So we expect patient to be seen here, and then 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 here. And this has its own problems and advantages. Because if you get road traffic accident and you are in the village, you'll be taken here. But this is a dispensary. They will not cannulate you. They don't have IV fluid. But do the community know that they can skip this and go here? Because here you can get IV fluids, you can get emergency surgery, you can get your x-rays done here, you can get good lab works here. Here you get more. You get more organized services. Here now you get SOA services, starting specialist SOA activities. Here you get more specialized and subspecialized. You start getting neurosurgeons, ENT, maxillofacial, start getting them here. Here you have everything that's available in a typical low middle income country. So moving this ladder is always a problem because if you jump the referral system, you are treated as a private patient and you are no longer public because you are supposed to move along the referral system. So that's a problem. So we had argued that for emergency, patients be treated as they arrive. So we are only following this with cold cases. So if you have a hernia, you have to move slowly. But if hernia is obstructed, you can jump. So emergencies can jump the referral system now. It used to be difficult. So these are the total number of health facilities that we have in Tanzania, with dispensaries accounting for the majority. and health centers, both government and public, and hospitals, that's from here to here, are 404, private and public. Unfortunately, private is only taking care of 8% of the population, the insured, and they leave the rest to government. So when they are taking 8%, it means they are taking the funding, the 80% of the funding, which is coming from insurance, goes to the private sector, and they leave the government with funding problems. And that's one of our biggest problems. So in one of the restructuring of the national insurance system is we are now forcing a referral system through government network. So we are forcing the insured to go through the government facilities. And that's done by disincentivizing, lowering down the prices of procedures and items that would disintract the private sector to allow the government to go through the public hospitals to get funding, where patients would be treated for free through exemptions. Next. I think this is a repetition. Next. So to address our SOAR services, we improved health services. Over 200 health centers were improved to offer cesarean section. The funding was purely for cesarean section. We call them CMOC. For those who are, I think our anesthesia friends understand the Safe Motherhood initiatives, the CMOCs and BMOCs. So they were funded heavily. So through their funding, that's how we got the additional operating rooms in the health centers. And we as surgical societies, we have utilized the same to build capacity for those hospitals to do the surgeries that have been categorized as essential. So they can do hernia, they can do hydrocele, they can do bowel obstruction, we teach them how to put stoma, and they can do trauma, they can take out the spleen in trauma, they can put colostomies. So challenges have also increased with this because you increase 200 facilities with services only provided in the district hospital and above. We already had shortages, both in resourceful anesthesia, which is being supported by our nurse colleagues, and the medical doctors capable of doing surgery. And on top of that, you increase sudden overnight, 200 new facilities. So for the first time, the government recruited the largest number of medical officers ever. We recruited 1,000 of them and deployed them to the 200 health centers. So these were people who had graduated like 4 or 5 years back, unemployed, no skills, and yes, an employment. And when employment comes, the criteria is you take the person who graduated the earliest. So you are not taking the person who is just out of internship today. So you have to go back 5 years ago. When did you last recruit? So that's the group you recruit. So they come with complete decay of skills, both surgical and medical skills. So that was a problem, and our maternal mortality doubled. And it was never reported. Now it has gone down because now they have been there for 3 years. They have gained some skills. They know when to refer and when to retain. Yeah, but it's an area where we can still work together to develop essential skills package for rural surgery, knowing that you are going to offer a package to people who are not trained as surgeons. Anesthesia is still weak. We have nurses who train, who are brought to the National Hospital for 6 months, and you return them to work. And what do? They have an anesthetic machine, but they don't have oxygen. You give them anesthetic medicine, you do not guarantee that they'll get oxygen. They can't intubate. They are comfortable giving spinal anesthesia, but they cannot manage the complications of spinal anesthesia. So they go into ketamine. I don't know whether the rest of the world is still using ketamine, but those are the most commonly used drugs, ketamine and spinal anesthesia. So you're reading any data from Africa, and they say surgery was done under general anesthesia, and that hospital is not zonal and above, rest assured it was done under ketamine. So you look at a surgery that's going to last more than 25 minutes under ketamine. Ketamine only works the first 25, 30 minutes. The subsequent ones you'll be using ketamine every 10 minutes. And where would this patient recover well? In the ward or in the ICU with all the ketamine you have given? So that's a big problem. So normally when I go out, I tell them only do surgery at this level if patient is dying. If death is not imminent in the next 2 hours, refer. So that's always my advice. If patient is chronically like chronic bowel obstruction, I will tell them refer because they don't have any lab at the health center. You go to the district hospital, they don't have any lab work. So they will not know what electrolytes are like. So I will still tell them, give fluids and refer. Only deal with acute problems. Patient, sudden abdominal pain, peritonitis, you can deal with that because the electrolytes will be okay. It's common patient to come with a perforated peptic ulcer that has been there 7 days or more. Volvulus that has been there, not passing stool for a week or more. It's common. So those type of patients, I will tell them refer. Fatigue is a big problem. Recently, in one of the health centers in Tanzania, in the northern part of Tanzania, an anesthesiologist had gone off the phone. And there was an emergency that came to the hospital and we had electricity rationing. So he was in the hospital for the past 48 hours. Now he was tired, he went back home and they could not reach him by phone. And there was an emergency that just came. And when they went home, they did not find him because he left the phone on the charger and went to the market. He has been working for 48 hours. Now the woman died and the politicians were on him. Now you look back on how to staff this facility so that you deal with fatigue because these people cannot work 24/7, 12. It's not possible. They'll make many errors. And this is the problem that we are seeing now, that you only have one person in a facility that can give anesthesia, and you only have 1 or 2 persons that can do surgery. And these people will go on annual leave. These people will travel, collect their salaries in the urban center. So it's an improvement, surgery within 2 hours, but with problems to human resource and retention becomes a difficulty. So with COVID-19, the weaknesses that were exposed were addressed by the funds that came. So we did not have diagnostic capacities before in the regional hospitals. So many surgeons would not want to go to the regions. Now we have CT scan for every regional hospital, and we have well-improved laboratory services for all regional hospitals, and we have an MRI for each of the zonal hospitals. We have ICU infrastructure. Actually, at least each hospital has 8 ICU beds fully equipped. We have EMD departments established in all the regional referral hospitals. We have improved blood services. All of them have regional level blood services where blood is now brought to them and they test it and return to the district hospitals and below. All of them have got oxygen producing capacity. So the regional hospitals produce oxygen and they distribute it to district hospitals and their health centers. So now oxygen is not a problem in most of the hospitals in Tanzania. But still, investing in infrastructure is easy. Human resource. Who is going to run the ICUs? Who is trained in critical care? So you have a room, yes, you have infrastructure, you have equipment. The motivations for investing in infrastructure are different from motivations of investing in human resource. Yeah, there's no 10%. So how do we develop our workforce? Traditionally, we only trained from one university. And when we were joining our program, surgical residents were hardly 3. Sometimes the department went without a resident. And it was the only university training residents. So we were the first largest class. We were 8 when we joined. And we were potentially funded by World Bank to recruit surgery, anesthesia, and obstetric and gynecology. And more universities were started like SMC in the north, Catholic University in Lake Victoria region, University of Dodoma in our new capital, Herbert Kairuki and Aga Khan are new arrivals from private universities. Now annually we produce close to 80 surgery, urology, orthopedic, neuro, ENT, oral maxillofacial, close to 80. We had looked at, if we can distribute just this 80, we would solve all the SOA services overnight. Because we'll be producing over 80 for the past 5 years. But out of the 80, only 5 or 6 would accept and go back to where they came from, because they will have all been employed somewhere lower, either in the district hospital or regional hospital. Only 5 or 10 would go back. The rest would be absorbed where they trained or would remain in urban, because private hospitals are also growing every day. They're increasing and they're employing. So that's the biggest problem we have. Training aspect is doing good. We're also training through CHESA. Not very much. We have about 5 or 6 graduates so far. This year we have the largest number of trainees through CHESA. The only problem is they're training in the same hospitals that are training the non-CHESA programs. So congestion in training. Yeah, so Dr. Mwanga would be having 70, 80 residents in the department using the same hostel shared by another 40 CHESA trainees. Yeah. So when our programs began, we were running a 4-year program. Then we lowered it to 3 years so that we accelerate the rate of graduation. And now we are going back to 5 years. When we recruit next year, we will be training for 4 years. Why? Because they are not being employed. So they are coming naive. They are new completely. So training them for 3 years would not be sufficient. When we are training them for 3 years, the assumption is they have completed their internship and worked for 2 years, did some surgery, C-section. So they are mature trainees. So 3 years was considered adequate. So we offer an MED program, which we inherited from UK. All UK colonies run MED program in orthopedic, general surgery, ENT, urology. And now we are starting an MED program in neurosurgery. We've realized that training neurosurgery at subspecialty, they are not moving out of Dar es Salaam. So you better lower their training. It's not a subspecialty. Actually, it will allow them now to pursue subspecialties in neurosurgery, but they will have to go first to the regional hospitals to offer the much needed neurosurgical services in the region. So from this year, neurosurgery will be at MED level and not at subspecialty post-MED level. But we still offer pediatric surgery as subspecialty. We offer plastic and reconstructive surgery. Cardiothoracic surgery is a 3-year program, and surgical gastroenterology and hepatobiliary with potential for future growth into transplant surgery and probably surgical oncology. We have a sizable being trained abroad, and we have problems here. We have much problems here. Training abroad, where do you train? If you train in the region, if you train in Kenya, Uganda, in the region, it's okay. You will train like one of them. If you train in the East, if you train in China or you train in Russia or Ukraine, you'll be observing for 3 years. You don't have license to practice. They don't demand you have a license to practice in their country. And you come back and you are not honest. You're saying you trained. And many of them are graduating from here. They will never accept to be posted where they will work alone. They will work where they're already surgeons so that they learn slowly. So it's becoming a problem, and the medical council is now subjected them into rigorous assessment. And last year alone, we refused recognition to 80% that trained abroad for lack of skills. One was an anesthesiologist who was taken to our skills lab and given everything and told to just select drugs to give anesthesia to a patient, and he could not. And finally told, okay, they just intubate this patient and place on the anesthetic machine, and he could not. But graduated from China with MED in anesthesia. So we are having problems with training abroad. We prefer to train locally or within the region. Next. Oops. So this is our current workforce. This is data that I used last year during our surgical conference. And we have a total of 332 general surgeons. So if you look at this, these are active duty, not retired, not dead. These are active, they're available. If you look at this, for 39 regions in the country, you fail to understand why you don't have at least 2 surgeons for each regional hospital. Why you can't have at least a surgeon for a district hospital. You can't understand. It's difficult. Urology, with the aging population and the BPH, you can't understand why you can't send 1 urologist for each regional hospital. Last year alone, we graduated, is it 14, Mwanga? 14. So now there should be 32. And this year we are graduating another 17. You can't understand. So our problems are distribution. They are no longer in training. You will train and train and train, and this number will just be increasing, but they'll be remaining in town. Look at our orthopedic, 169, and you have 50% of our regional hospitals without orthopedic surgeon, in spite of border accidents and trauma. All the 9 neurosurgeons are in 4 hospitals. 5 in Dar es Salaam, 1 in Mbeya, 1 in KCMC, 1 in Dodoma, 1 in Bugando. What do you do when you are 1? You don't go for your off, you don't go on annual leave. We don't have locum, mind you, in Tanzania. When somebody is absent here, you bring somebody to cover. You are not covered in Tanzania. When you are absent, you are absent. Anesthesia workforce, I was happy to learn yesterday that we have 85 anesthesiologists. And you cannot understand why only 6 hospitals have anesthesiologists. 6 public hospitals have anesthesiologists. A distribution problem. The 1,450, this is a mixture of nurses, clinical officers, and non-physicians supporting anesthesia. Even in my hospital, I am more comfortable with these ones because they're the ones I see every day. They're the ones we work with. They're just so good. We don't see the anesthesiologists in the room. They're in the clinic. So we have problem. Recently, we introduced a bachelor in science, nursing, anesthesia. We graduated the first 20, and they have a problem. They don't want to be regulated by the Nurses Council. They want to change from Bachelor of Science Anesthesia to just Bachelor in Anesthesia. That's a new cadre. And you know, politically, starting a new cadre, you have to go to the Treasury and tell them what that new cadre would mean in terms of salary. Starting a cadre, a practice within an existing cadre is easy because Bachelor of Science Nursing is already salary. So you only have Bachelor of Science Nursing, but in anesthesia. So we are taking anesthesia, nurses who have trained at diploma level to be nurses, and now we are giving them a 3-year program to practice anesthesia. So this is new. We just produced the first 20, they are completing their internship in Muhimbili. The aim is to take these ones to the health center level. I don't know whether it will be possible. Non-surgeons offering surgery are the bulk, medical officers and the non-physicians. We have non-physicians would be clinical officers who got additional training at advanced higher diploma level. We phased out the training 7 years ago because we were only producing 100 of them a year. And they were meant to bridge the gap of the absence of medical officers. When it was started, we were only producing maximum of 50 medical officers trained inside and abroad. So bridging the gap of workforce that was needed to health center using medical officers was not going to be easy. Now with over 3,000 medical graduates every year, we thought that it was time to improve the quality of service provision by phasing out the non-physician assistants and bringing the medical officers to cover their roles. Next. Keep stacking. So with all those, we have seen challenges and opportunities that I can see are collaborations within the region. I was meeting my COSEXA colleagues and our common complaint was we are not collaborating well ourselves. We have to wait for somebody from outside to collaborate with. So if we can work like in Tanzania now, we are working with CHESA, and we are sharing similar activities between Tanzania and Uganda. So if we can leverage on those and work together regionally with CHESA as our hub, so that we replicate whatever is being done in Uganda to improve patient care, improve training and skills transfer, exchange of students and faculty, build research capacity, and local capacity strengthening of surgical education through programs development and expertise are areas that are very important to us. Otherwise, thank you so much.
Akoko, thank you for an incredibly thorough presentation. I wonder if, I know we've gone a little bit past the hour. Everybody on Zoom, thank you so much for staying on, and everybody who's in the room, thank you for staying on. We have the room for longer, so we can extend the program for a bit. Dr. Mwanga, I wanted to invite you also to share your comments. Dr. Ali Mwanga is the head of Department of Surgery, and also give you an opportunity to speak. And then we'll take and then we'll open up for some questions.
Hello, good morning. Yeah, thank you very much. I should start by my friend, Professor Akoko, for a very well elaborate presentation on the surgery in Tanzania. Thank you very much. And also I should thank CHESA for organizing this event. And I think it's very exciting to see what are the development which is going on. However, mine is more of thinking, and I should at this one point not hesitate to mention University of California, San Francisco, and therefore going down to the Department of Surgery, especially through Professor Bill Schechter and his colleagues, Professor Dr. Gray, and many others. In the past 10 years, we have been working on these challenges which have been highlighted here, have been there since ever. But I should admit, for the past 10 years, there have been tremendous improvement, especially in the arm of surgical care at the tertiary level. To mention Muhimbili National Hospital, where we work, we benefited a lot working with Professor Bill Schechter under the Alliance for Global Clinical Training. And a lot happened. You see, one of the challenges that were clearly highlighted is the workforce, critical care. We meet patients at the advanced stage of the diseases, like a patient with peritonitis. Imagine the patient had been missed from the dispensary level more than 2 weeks before we see the patient at the tertiary hospital. This is the very sick patients. And therefore, critical care was missing. Nurses were not well trained in as far as taking care of the critical ill patients. So thanks to Bill Schechter and the colleagues, they came over, we started working, and we as surgeons, we were trained how to take care of the critical care. So it's like we operate and we have to take care of the patient at the ICU. And through that, there have been a lot of achievement, improvement. Even nurses who were not trained are learning slowly through us. And this one, I should mention that. Thank you very much. However, you can see all what have been presented by Professor Akoko sounds very good. These are very good write-ups. However, in the field, things are not that way. Things are still, we have so much challenges at the country. And therefore, this is a huge opportunity, meeting you colleagues, meeting you, and these are the areas that we can collaborate and see how much we can improve. We have a very good write-ups on how beautiful things should be, but in reality, things are not at that capacity. So thank you very much once again.
Thank you, Dr. Mwanga, for adding to that, and again, Dr. Akoko for such a thorough presentation. So I don't see Dr. Schechter or Dr. Gray on the Zoom, but also for all of their efforts over the last decade and more to work with you, especially around improving clinical training. Maybe we could open up for a few questions in the room, and then there are some comments that have been on the chat that I know you can't see up front that we'll also share. So I don't know if Adrian or Peter, you had any comments or questions?
Well, I learned a lot. I have a couple of questions about the insurance, the national insurance. That's number one. And then my other question is very, you know, we've spoken earlier in the week about facilitating the development of dialysis and transplantation. But you know, and just hearing the overall landscape, I wonder what your thoughts are. First of all, with the insurance piece of it, but second of all, if you think that it's practical to even consider the development of transplantation in the absence of the development of dialysis. And along that line, I was wondering what the national insurance is doing in terms of coverage for dialysis.
So initially, I think before 2020, dialysis was offered at the zonal hospitals and a bunch of private hospitals. So patients would travel distances for dialysis. So even when you lowered down the price, the travel cost is still there, not lowered. So the days lost just traveling were enormous. So the government rolled out dialysis to regional hospitals. It's still not there because people are not living at the regional headquarters. People would still be coming from district hospitals and people would be coming from their communities. So it's a disparity. It's people who live closer to the regional hospitals would access it much better now, and it's cheaper. So now we have dialysis in all the public regional referral hospitals. One of the other things that came with it was having dialysis access created at the national hospital attracted something closer to $500 per patient. Having dialysis taken to regional hospital, access surgery that we have been running with Stephanie Lin and the group cost less than $50. So, and that was the argument with the ENSA, that as services go down, as we improve them down, they become cheaper. Cheaper in terms of travel cost and cheaper in terms of costing, because they are less complex structures. But whether at the current level of services we need transplant or not is an issue we are discussed, that you have not addressed the bellwether properly. Why are you moving? So one of the problems that we have gone into as a country, the budget for health has increased tremendously, but there are still shortages. Why? Because we increased budget, increased complexity of things that are being done for the few. So the common things that would be done at less expensive costs are neglected because these are in the election manifesto. So sliding with the election manifesto, what we call when there's a political will, we just need to find out to inform that political will to our advantage. But currently, we are enjoying that political will of wanting to do more. So it's our role as academia and collaborators to find how to positively engage to make sure that transplant services are growing hand by hand with the supportive services that are necessary.
Thanks, Dr. Akoko. I wonder, Adrian, if you had any comments on the discussion on surgery and anesthesia.
Sure. Thank you for a very comprehensive presentation, which I really enjoyed. We are going to meet, I think, in an hour, so we can talk in a little more detail about anesthesia issues. It was great to see you use the Lancet Commission framework for the discussion. This is the 10th anniversary year of the start of that Lancet Commission process, and gives one a sense of how long change really takes, a decade. There is some discussion now among some of us that it's time for a re-review and a reformulation of the value proposition of surgical care or operative care. So stand by over the next couple of years. In terms of infrastructure versus human resource, my cynical impression is politicians like infrastructure. Sure. Their name goes on the door in perpetuity. Politician funds a whole lot of medical students. None of us walk around saying, my medical education was funded by Adrian Gelb, the Minister of Health. And so there's a little ego issue in that, and infrastructure is instantaneous. We have an election next year, we can build a hospital in your community, vote for me. Train a surgeon or an anesthesiologist, well, that's going to take 2 election cycles. And so cynically, those are issues we need to think about in terms of the politics. Tanzania used to be, maybe still is, a poster child for a country that exports physicians because of that disconnect between number of medical students and available jobs. I'd be interested to know if that's still the case. And a second question, which relates to your use of bellwethers, and just to point out the metrics have been revised and updated. I can share that with you. The concept of the bellwethers is if one could do those 3 crude procedure categories, a hospital could do all surgical procedures. And it would be interesting to know if that's been your experience, because my experience from outside is a lot of places can actually do those 3 procedures, but when you look at other surgical care, it's at a very rudimentary basis. So maybe it isn't the best metric after all.
Yeah, thank you so much. I think I've been fighting our medical students when they train and they go jobless. And I tell them medicine is a global commodity. Should not stay with it home if they need it somewhere. So I'm one of those who would encourage them to find a job wherever it would be found to practice medicine. Unlike from the affluent families, they study medicine and do something else. They're not doing medicine. So Tanzanians are not going out a lot. I don't know why. Unlike our neighbors in Kenya, who are all over the southern region. Tanzanians are going out very little. Actually, my knowledge, even Tanzanians who came to Tanzania and are doing medicine are not more than 20. Even in UK, they're not going. I don't know why, whether they're afraid of exams or they like home more. So it's a privilege that they would like to stay. And as you said, politically, it doesn't sound. When we have the late Magufuli, politically, it was okay with him. I hired 1,000 doctors, opened 200 health centers doing surgery. And nobody's replicating that. That was 2018. 1,000 doctors were hired and sent out. Yeah, but as you said, we have over 8,000 or so unemployed doctors. Bellwether, as I said, doing surgery as an art is easy. And if Bellwether intends to look at the art of doing it, the ability to do it, it's okay. But I look at the whole infrastructure, perioperative care, it's missing. So I go to a district hospital with Dr. Mwanga, and many a times you feel like there's very little I can do here, very little, because you want to know what's the electrolyte like, it's not there. Is there an infection? It's not there. What if patient going to Aki, which is common in peritonitis in Africa? It's not there. What type of suture do they have today? It's a suture you'll not put on a boil. Yeah. So in spite of all that, I just forgot to mention that pediatric surgery is the most suffering, because kids can only be operated either at the National Hospital or at the 4 zonal hospitals, and they are the majority in the population. So whether we need pediatric surgery training to continue being a subspecialty of surgery, I have a different thinking. If we have to address pediatric surgery, then it has to be a training after the MD, not to wait until somebody becomes a subspecialist, because then it's not very rewarding. Many people would not like, would mix practice, would mix adult and pediatrics. Like myself, I mix both adult and pediatrics. So they will not dedicate themselves fully to pediatric surgery. So that's one of the most neglected, given that ketamine would not be the best anesthesia for kids, and spinal anesthesia is out of discussion. So both the lack of pediatric surgeons and the lack of anesthesia is a big obstacle. And whether we can use the under 5 mortality supporters to support pediatric surgical services is something that we can explore together.
On top of that, I'm lucky that now we've gone through CHESA for the pediatric surgery problem. We had some discussion and
Yes.
we are bringing it again. Thank you very much.
Thank you, Dr. Mwanga and Akoko. There are a couple questions. I would have a lot to say about pediatric surgery, but I know we're quite over time. But there were a couple of comments and questions. One from JP Sendyondwa, who is one of our CHESA fellows in Uganda. And there were quite a few Ugandans. There's about 30 folks on the chat. But JB was asking whether you face the challenge of competing with the physicians, meaning the internal medicine physicians, for funding by the government. And if so, what come those challenges to try to get funding for surgery versus internal medicine, which sometimes gets more funding, especially for the infectious diseases? Yeah.
So we don't have challenges. Actually, every year the Ministry of Health will list their priority areas that they are going to fund, and internal medicine would not be one of them. So it would be surgery. It would be some things you won't like to see in the list in a developing country, like if somebody says fetal maternal medicine is a priority. How can it become a priority while you cannot handle a kid who is born? Cannot offer surgery to a kid and you want to offer fetal maternal medicine? Or somebody says priority is family medicine, while you cannot send a specialist to a district level hospital. Where are you sending the family physician? Yeah, and these are coming with the lobbyists from both here and Aga Khan locally to promote family medicine in a country that cannot offer the basic specialty services. So yes, we don't face, actually, if anything, there's a lot of priority in surgical training in Tanzania.
But it's a great question because so many of the challenges you're raising are very common in the entire region and LMICs, and each place some strategies work and some don't, and in some places some are challenges and some are not. There also were a couple of comments from Gareth Wood, who had to leave the call, but is the founder of Kids OR. And as you know, they built the Kids ORs in Dar,
in Tanzania and Bugando.
Bugando, and he commented on the fact that they have a new solar OR setup for some of their ORs to try to actually, for those periods when electricity is gone, actually keep the OR functional. He shared that thought. And then as well as he mentioned that it seemed like the costings for the SOA, the workforce, seemed a little bit high. And so I wonder if you could talk a little bit about the costings for the SOA and whether there was that, how you did that.
And I was just going to chip in a comment about solar. There is an alert across North America for hospitals that use solar power during the eclipse. There will be no solar power.
Okay, interesting. Okay.
Yes. So
sorry, go ahead.
Yeah, so the question considered the numbers that would be needed. So as you saw, the costing for human resource was increasing as you move across. And that basically, if you look at the NSWAP, it's available online, we were counting numbers. So as we were moving like year one, you would not expect to have all the specialists you needed. So the costs were low. So since we started NSWAP, we figured out in year 3, we would have trained and needed to employ those who are not employed. So the costs were high in terms of salary and training. So we costed both. What would be their salaries and what would be the costs of training them? So where the costs went high, it was because of training. And I must say that the training has been well attended. The numbers increased. We were not happy in the department. The numbers were quadrupled. 50 people would apply to do surgery. and would say, no, we can only take 20. So the numbers increased. So we funded that human resource aspect partially. What did not happen is if they came to training without employment, they were not employed. Unfortunately, those are few. Many people who come to training are already employed, which is good because they already have a salary. So actually, that salary was not going to be used if we were to just redistribute. If everybody coming to training would be returned where they came from, we would be having SOA all over without all that cost. But the assumption was these people are not there. We are bringing them without employment. These are the training costs, and this would be the salaries should we employ them.
And along those lines, there was a question from Nabiyu on the chat about the high unemployment rate and 8,000 medical doctors staying at home. So can you talk a little bit about the unemployment of physicians?
Yeah, so the biggest employer of physicians in Tanzania is the government, which owns 85% of facilities. And one of the biggest problems that Tanzania has faced is the wage bill. The wage bill does not allow additional employment or absorption. So the shortage is there of the workforce. The people who are actually engaged to work. We have a shortage, but we don't have a shortage in the market. So in the market, people to employ are there, especially if you just want medical officers. They're there, plenty. If you want clinical officers, they're there, plenty. They graduate in 10,000 every year. For the past 4 years, the government has only been employing 100 medical doctors. And 3,000 have been graduating from internship.
Yeah, again, not a problem, I think unique only to Tanzania, yeah. But I think it's a common problem in many places. So
unless the private sector takes up, when we come up with universal health insurance, which will kick off after elections next year, I hope private sector will employ more.
So just a few more questions. I think we'll aim to finish in the next 5 minutes. We'll be done at 10:30. But one of the questions from Dr. Halak Lur from Honduras, an anesthesiologist with WFSA, and she's also on the advisory board of CHESA, was around basically the bellwether procedure for exploratory laparotomy at the health center level. What's the expectation of the procedures that should be completed during a trauma laparotomy, depending on what's found intra-abdominally? And what does the medical officer do when they encounter an injury that they don't know how to manage when they're at that lower level facility?
That's actually Caroline Stevens.
Oh, Caroline Stevens, sorry. Okay, one of our residents in CHESA fellows. I couldn't tell, sorry.
Caroline, I like the background. Yeah. So one of the problems, that's why I said that we need a package for training the rural surgical workforce, not rural surgeons, rural surgical workforce, because we are not very sure. Because even in my tertiary level hospital, where I don't take calls regularly, I would be called by a surgeon who has been working for 5 years. They have opened a trauma and they don't know what to do. So if that can occur at the national level, it will occur also at the lower level and with more frequency. So Bellwether expects the medical doctor to be able to relieve obstruction, do bowel resection, and bring out a stoma, take out a spleen, repair a perforated peptic ulcer. That's the list. So they must have tried up to that point. When Bill Schechter came, he told us, I think it's the principle here, that, okay, patient has multiple trauma and you are only competent in the abdomen, but you also think there's a problem in the chest. So what do? You do the abdomen. If patient survives with your abdomen, it's okay. If they won't survive because of the chest, you did your best. You won't cry because you could not. So when they commit to open, it's because they thought they would meet something they would manage. And my advice to them is always, can the patient reach the next level? If the answer is no, then try and do something. If the answer is yes, try and take them to the next level. Actually, in my opinion, I would want to discourage them to do any surgery electively, which they do. So you find themselves exhausted by elective or very non-emergency cases. Like, why would you have a cesarean section in a woman with eclampsia? in a health center, while you'll not be able to offer comprehensive care for eclampsia. But on the other hand, how do you transport a woman convulsing on a rough road? It's not tarmac. So you are caught up in a very real dilemma when you are in such a situation. So I've spent some 5 days or more doing hydrocells, and I keep pushing all their referrals to the district hospital. And I always hope that in my absence, they'll do the same. So I'll put an IV line, I'll put a catheter, I'll make sure urine is flowing, I'll make sure fluid is running, and tell them, just send this patient to the district hospital. They have all the resources to take care of what you'll not be able to take care of here. When a simple case comes that would not make it to the district hospital, then we would open together. And I always want to tell them that's why they are there, just to make a difference between life and death. If they can do something minimal and refer. Otherwise, exhaustion is real.
Maybe we'll take one last question. Thank you for that, Dr. Akoko, was about this challenge of recruiting, the maldistribution and the recruiting to rural areas. Not something that's unique to Tanzania. It's common in the region, it's common here. But one of the things that in Uganda that they've done is try to recruit surgeons and anesthesiologists in pairs, make sure they have a home, maybe incentivize them with some salary, maybe incentivize them with some scholarships. So what strategies have been tried to actually address this maldistribution? And what hasn't been tried that you think should be done to tackle it locally?
Yeah, so it's a multifaceted approach. Ethiopia will not give you a license until you practice in the rural for 2 years. Then you can go wherever you want. During those 2 years, they will try to make you being interested with that area by giving all those incentives, and you remain. My experience is when we were medical doctors, there are regions we would not accept posting because we don't know them. It's not where I came from. So what we did at medical council level, where I take part-time activity, is we created internship centers. So you need to go to internship, you have to go to that location because they don't know it. So now you have medical doctors all over. They would remain where they were not going before. So we were thinking whether the MED program, the additional year that we are adding, should be spent in a more rural place so that they just know that they can work there also. Many of them don't know that they can also do surgery. And there's a misdefinition of what is surgery. And people think that doing a mastectomy, doing a gastrectomy, doing a colon resection for cancer is what is surgery. And doing all the emergencies is something for the medical doctor. I think that's the biggest problem that we have. So a surgeon goes to a regional hospital and they will be asking you, what will I be doing here? So I think just telling them that those who need some additional training, and this is what you can do now, would be one of the options. Having them stay part of their training in the rural would be another option. What has disincentivized people from going in the rural was so obvious. It's finance. If you work where I work, you see private patients, and on top of your salary, you are being paid by the same government, twice your salary. And there's lots of private practice around you. So everybody would want to remain. You see, going to the region like a punishment. You are alone and you are not being given anything beyond your salary. So the argument was to relook at what we call IPPM, intramural public-private practice, and come up with a motivation scheme like the one they have in Japan, or the one I found in India, where you get a salary plus a factor. They don't incentivize you on the head of a patient, because that's a moral hazard in insurance itself. You'll be doing procedures that should not have been done because your motivation depends on doing a neotomy or a neuropathy on a patient. So for every neuropathy, you get 40% of what they paid. Moral hazards became so high. So what we're trying to look at now from the Surgical Association and working with the government is to find a fixed formula where you say that if you're working in a regional hospital, this is what you'll be given as a compensation for your private practice, because all these hospitals have both public and private practice within them. Yeah. So yes, we need to explore more what would work.
Well, thank you for that. There are a lot of other comments, mostly just a lot of gratitude to you and Mwanga for sharing all of this and for continuing to work together with all of us. who look forward to more collaborations. Dr. Sosa was on and said thank you very much, and was very glad you were here this week and that we were able to meet yesterday. But mostly everybody who's on Zoom, thank you for staying on. We're over half an hour past, if many of you stayed. We'll make this recording available to everyone. And again, thank you all for coming. I think we'll end the session now. And for anybody who's on Zoom, please reach out if you have any questions or need to get in touch with the speakers. So,
thank you so much.